positions in quality improvement and regulatory compliance for both behavioral health and intellectual disabilities organizations. He has a substantial background as a liaison with local, state, and national regulatory body and accrediting bodies. He's currently serving as the Vice President of Performance Improvement and Compliance Officer at Child Guidance Resource Centers. As you all know, CGRC provides services to children and families in outpatient and community-based settings in all 4 counties, Delaware, Chester, Montgomery, and Philadelphia counties. Prior to this, he was Director of Corporate Compliance at Melmark, a large provider of services for children and adults with intellectual disabilities and autism. Melmark, we consult for medication management right now. It's over 35 residential sites in Delaware and Chester County. And Mike also had numerous positions previously at Meraki. These included Eastern Region Coordinator of Quality Improvement for Intellectual and Developmental Disabilities, Director of Program Evaluation of Adult Behavioral Health Services, and Director of Training for Adult and Children's Behavioral Health. Without further ado, I'll give it to Mike. Let's make sure that you are able to share.
I think that I am.
Okay, good. Thank you, Mike.
Thank you. Thank you. Thank you for that introduction, Dr. Musunori. As you said, I'm here today to talk about implementing the Zero Suicide framework. You and I discussed this a little bit as an organizational approach to ensure best practices related to suicide prevention. And I really appreciate the opportunity to talk to you all. If there's a way for people to ask questions, how would we do that? Would they put it in the chat? Or
yes, they'll be putting it in the chat. I can look them over and we'll address them at the end.
That sounds good. Thank you. So thanks for the introduction. As described, I've spent most of my career in doing something called quality improvement, looking at organizational systems and trying to improve them to ensure ultimately the best quality of care gets delivered consistently across a multitude of different programs. And I worked in those organizations that Dr. Musunori described, and I'm currently at Child Guidance Resource Centers. Since I work in quality improvement, a lot of what I do has to do with Joint Commission accreditation, and I've done that at a number of organizations. The Joint Commission, as you may know, is the leading accrediting body of healthcare and behavioral health providers in the United States and really sets the standard of care for best practices in behavioral health. So, so in doing that and working with the accreditation process, I've been confronted with the Joint Commission's #1 priority, which is safety, and the #1 risk to patient safety, client safety in the behavioral health field, as I'm sure you know, is suicide. So, so a lot of my efforts to comply with accreditation requirements have been devoted to developing best practices in suicide prevention. So that's how I came to have all of this information. And what I want to do today is just share with you how we learned about the Zero Suicide framework, how we applied it, and some of the benefits we achieved from it. So hopefully I can transition to a slideshow. There you go. Ultimately, when we had invested a substantial amount of time and resources and leadership in evaluating ourselves related to standards by Zero Suicide, what we identified were 3 important steps to prevent suicide. And these are things that we're currently working on at Child Guidance, and things that organizations, I think, out of a number of standards, typically prioritize when striving to adhere to the zero suicide framework. So not necessarily in order of priority. I think they all pretty much are high up there on the list, but actually probably number one in terms of a system priority is developing a competent, confident, and caring workforce. And I'll talk a little bit about that, but competence and confidence when assessing for suicide risk and responding to suicide risk and treating suicide risk, despite all of the credentials, experience, and training that people may have had, is not something you can assume exist without evaluating it. And that's one of the most important lessons that we learned, was the importance of formal evaluation of competence and confidence. Transitioning are always challenging in behavioral health, moving from one program to another, one level of care to another, one organization to another. And in the context of transitions, depending on the population you're working with, for us, it's a community-based system that we work within, and we collaborate with a lot of other inpatient and community-based providers. Transitions are risk areas for us, and for individuals when it comes to hard to reach individuals. So, one of our goals is to put best practices in place in engaging hard to reach people and maintaining contact with high risk people who are not showing and not following through. So that's also kind of consistent with the state and our managed care organization standards related to discharging from inpatient units and connecting quickly with community-based or outpatient providers as one of the best ways to reduce risk of readmission or further problems with people who have diagnosed with mental health problems. And finally, for us, a really significant area that we learned we needed to address was planning for lethal means safety, and just the common sense of reducing access to lethal means and the value of a relatively straightforward investment in educating people about access to lethal means and the impact that has on reduction in suicide attempts and reduction in lethality of suicide. So this for us, these are things we're currently working on. As I said, typical of things that organizations who use the zero suicide framework and implement it, typical of the kinds of areas they end up addressing. So in our case, as I said, my experience has really been working with the compliance with Joint Commission standards. And for years, as I said, Joint Commission has really emphasized screening and assessing using validated screening tools and standardized assessment tools. We use and have been using the Columbia Suicide Severity Rating Scale, a number of different versions, the screening version, the full version, and the version that has something called the safety embedded in it. And I think over the years, we've done a very good job at implementing screening and assessment processes into our organization and into our admission and transfer processes. So we did well with adhering to that standard. And over time, after becoming really good at assessing and reassessing, we got to a point where we were seeing both externally increased expectations, evolving standards for intervention with suicide risk, and data that was telling us that we needed to be more effective, both our own data in our organization as well as as you may know, the CDC, the World Health Organization, a lot of nonprofit organizations that are grant funded have studied suicide risk over the years, and there has been a trend of increased risk, especially among adolescents, going back pre-pandemic up to almost the present time. And I think I don't need to do this, but feel like can you guys see this?
It's not, something is going on. with this part.
Something's going on. All
Yeah,
right, hold on.
maybe do it again.
One second. How about now?
Yeah, we can see it.
I could show you tons and tons of statistics like this and graphs like this, but overall, the theme is repeated again and again. Generally speaking, adolescents are at increased risk of suicidal thoughts, suicidal behavior, and suicide attempts. And some of those risks for that population are exacerbated by socioeconomic factors, um, by um, by gender issues, by family history, and by geography, but generally speaking, the adolescent population is really what we're focused on at the organization I work with now, and it is a population that is receiving great attention due to ongoing increase in suicide rates and suicide risk. So from the youth behavior risk surveillance survey that the federal government does, I've seen statistics that say about one in four high school girls thinks about suicide, and significant percentage of high school age adolescent girls make plans for suicide. So, we're seeing that what's in the general population reflected in an acute way in the services we provide to children and adolescents. So, so all of that is to say that that it never stopped receiving our attention, and we never stopped striving to build better systems to address suicide risk. Don't think that we're where we need to be, but we don't think that the United States is where it needs to be. And we will no doubt be dealing with this issue and striving to improve what we do for as long as I'm working in this profession. So getting to the point where we've done really well with screening and assessment, based on that increase that I showed you and our internal data that showed increasing suicide attempts and psychiatric crisis for adolescents, we're driven to do more and more. So beyond assessment and beyond screening, we started to focus on better interventions, beginning with fundamental crisis prevention and safety planning approach. And we implemented the Stanley Brown safety plan, which some of you may be familiar with. We tried to build on that and look at our interventions as not just responding to crises or responding to high-risk situations, but preventing them. So we layered protective and proactive strategies and strengths upon our crisis safety plan. And we like to think that we include components to maintain wellness and build on strengths and coping skills in addition to strategies to reduce harm when a crisis arises. We've systematically implemented a system for reassessment of high and moderate risk individuals. So we do that at every session frequently or at regular intervals, depending on the program that a person is in. And despite all that, I continued to look for resources to put the best practices in place and look for resources to provide an overall framework. And in the course of doing that, after our last Joint Commission survey, I came across the Zero Suicide Framework. And I found it incredibly valuable. And a lot of it is actually free. A lot of the information that's available on the Zero Suicide Framework is something that you can access by the websites that I'll give you and just by Googling it. But essentially, what it is 7 elements that compromise or that summarize what experts in the field of suicide prevention have identified as best practices or components of safe and effective care for people at risk of suicide. And those seven elements include leading system-wide culture change, which I think you can't overestimate the importance of that, of making reduction in suicide risk an organizational endeavor. And that's something that that sometimes is a challenge, given the nature of what we do, is to have an entire organization, given the diverse roles that we have in a community-based organization, kind of all participated in one overarching goal of a safer community. So you can't overestimate the value of culture and leadership buy-in in implementing something like this. Training, a challenge, again, sometimes based on the resources that we have. And I'll talk a little bit more about our approach to that. Identification of individuals via comprehensive screening. I think we do well with that. Engagement using a suicide care management plan. That's something I think we've improved in, and still an area that we have as a one of our priorities. Treatment, using evidence-based treatments or referring for evidence-based treatments. Transitioning, as I talked about a little earlier, and a quality improvement system, a system that looks at the outcomes of whatever processes you put in place. If you put in assessment and reassessment processes, are they actually working? Are they being implemented? Are they yielding results that are driving interventions that are appropriate? So a system of quality improvement is also part of this framework. So that's the framework. That's the set of standards. For me, in my experience, it's an approach that is as helpful and as practical as any external accreditation or external set of standards I've dealt with in a behavioral health or human services organization. It's got a very logical approach and a very focused approach, and it's pretty much my #1 priority right now at Child Guidance Resource Centers. So the way to go about implementing a zero suicide framework is, first and foremost, get that leadership buy-in, get the top of the organization, the clinical and operational leadership, to recognize that resources need to be devoted to a comprehensive approach of measuring adherence to best practices and evidence-based standards across multiple functions in the organization. Get that commitment from the leadership of the organization and have it embodied in the formation of an implementation team and giving that team, a multidisciplinary team, a formal authority to make recommendations and move things toward implementation. So that is step one. And having that team represent, motivated, um, interested, and knowledgeable people who also come from, the diverse set of services and types of positions in an organization. So once you have that team, you assess compliance, adherence to the standards using a formal self-study tool. And I'll show you that in a little bit. Once you use that tool, you identify what you do well, and then you identify what you might want to improve. So here's an example of the self-study. Here's just, we'll call this a typical community-based mental health organization without identifying which one it is. But I can tell you that the tool has 20 items, and it's broken down into a number of different questions, starting with broken down by element, starting with leadership, and designed to define an organization's adherence to the framework on a scale of 1 to 5, starting with, no implementation, up through complete implementation, as demonstrated by a number of things, typical things you look for in an organization to demonstrate implementation of a process, starting with policies, procedures, moving to training, implementation, documentation. So section 1 of the self-study is about leadership, and there may be a lot of leadership, and I think we've had a lot of leadership and leadership support around addressing suicide risk. But there's some aspects of leadership that we didn't feel that we were completely competent in terms of best practices. And as I said, one of those is that team responsible for suicide prevention, and a team that actually has some authority to make recommendations regarding policy and is given the status of an official zero suicide implementation team. Another area that organizations don't always score well on related to leadership is integrating and establishing a role for suicide attempt and suicide loss survivors in the organization's design, implementation, and improvement of suicide prevention and intervention. So I think, there are organizations out there, families of people whose lives have been lost to suicide, things like that. And we can learn from them, and we can seek input from them in designing our policies and procedures and practices. And I think, from my experience, we work with these organizations, we can reduce some of the stigma and some of the fear that even our clinicians have related to talking about suicide. So another area beyond leadership, another one of those 7 elements of the framework is engagement. And engagement has a number of different processes connected to it. One of those is having a standard set of expectations for responding to suicide risk, policies, procedures. When you identify the risk, these are the steps that you take. And then safety planning. As I mentioned earlier, we adopted the Stanley Brown plan, and we've also got enhanced tools to build resilience and protective factors for people at risk of suicide. So we think we do a pretty good job with that. And as I said, one of the things that was enlightening for us was the importance in collaboratively planning for lethal means safety, the importance of reducing access to lethal means. So lethal means for us is when we look at lethal means, what we see is a range of risk areas. The most common means that we see is medication overdoses. So we've had, I would say we've had approximately 60 suicide attempts over the last 2 years. They have been decreasing, and they range with the population that we serve, from relatively high lethality to relatively low lethality. In the spectrum of lethal means, the one that we see most often is attempted overdoses. The profile for us of a suicide attempt is an adolescent girl who attempts to overdose on what is available. What is available for adolescent girls that we see is often the SSRIs that they've been prescribed by our organization. If there's anything that we learned, is that in some cases we are actually providing the means to the population that we're trying to help. And we've really tried to build in our safety planning to emphasize to clinicians the importance to reduce access to lethal means. And there's an excellent training called the CALM training, counseling on access to lethal means, that you can access through the Zero Suicide framework. And if you access the CALM training and register for it, you can take it online, and it's free. And it really goes beyond just lethal means counseling, giving some insight into the nature of suicide attempts. It does a good job of reinforcing the understanding that a lot of suicide attempts, maybe about half of them, people start planning for them within 10 minutes of the actual attempt. So the idea of a plan, which people typically assess for in looking at suicide risk, is important. But a lot of attempts aren't enduring plans as much as impulsive acts. And in those situations, there's what can make a difference in whether or not someone makes an attempt, and the lethality of an attempt is making sure there's limited access to lethal means. So again, the CALM training, the online training, counseling on access to lethal means, is something that we've required since we did this initial self-study a little over a year ago, and something that I think is actually paying off based on the data that we're looking at. And finally, I think doing the self-study, one of the things we came away with that was very valuable was formally assessing staff on their perception of their confidence and skills and perceived support in identifying and caring for people at risk for suicide. In my role in the management of a behavioral health organization, I've pushed for screening tools, for assessment tools, for approaches, for plans, for documentation, and realized what I probably didn't do well enough was ask our employees, how well do you feel this is working? How comfortable are you with using these tools? How confident are you in your skills in assessing for suicide risk? How comfortable are you talking about suicide risk with our clients? I think sometimes we have an assumption that because people are trained behavioral health clinicians and have certain credentials, that there's an automatic confidence in talking about suicide that comes with those things. And I think that's not the case. I think it's different. It's difficult for all of us to talk about suicide, even though those of us in this field know intellectually that talking about suicide with people doesn't increase the risk that they will attempt suicide. I think there's a part of all of us that needs to become comfortable with it. I think there's just an automatic, natural kind of a fear or a bias about that. And that's one of the things that we've encountered as an area we need to address. And the way we did that was not just by sending out a survey. There is a survey where you can meet this standard to formally assess staff. And it's a survey that it can be administered through SurveyMonkey, or it can be done in paper. The way I found most effective was actually to establish team meetings, groups, individual department groups, where we first talked about the issue, talked about our approach, talked about why we were doing this, and then gave people an opportunity to complete the survey. The survey is designed to be applicable based on a person's role. So some people may be at a role where they just identify and screen for suicide risk. Other people may have a much more clinical role where they are treating people with suicide risk as an issue. And the survey sorts out, based on role, confidence and competence in the types of work that you would do based on your position in the organization. And then it identifies of those types of work areas that can be improved, and elements of training that can be incorporated. The other thing that I found really valuable, and sort of goes along with doing a survey of staff and assessing confidence and competence, is demystifying quality improvement, demystifying and reducing fear around the critical questions of what could we have done differently, and could we have done something better when something bad happens. Because what I've learned in this business, in this field, is that bad things, adverse outcomes are going to happen. And often when they do, we do chart reviews, and we do questions, and we do interviews, and we do debriefings, and we try to discover what went wrong. And often people feel intimidated or blamed when that happens, and diminishing that feeling of blame, and trying to engage people in understanding the value of quality improvement, and in understanding that given the significant challenges we face based on the data that I just gave you a glimpse of, with the increasing trend of suicide risk and the limited resources that we have, we're not perfect, and we're all at every level going to have situations where we don't do the best possible thing. And those things are learning opportunities. And that's the way we try to treat them. And that's the way we try to get people to understand them. And I think that's an ongoing endeavor. And that's sort of the point of this slide. That adverse events will occur, but if they occur in a context of a systematic approach to improvement, and an understanding of all of our roles in achieving designated goals and work toward those goals, then those adverse events can be learning opportunities rather than, or in addition to, things that we feel somewhat sad about. And so, I really believe in this stuff, and there's evidence that supports it. not just what I've experienced in using it, but there have been studies in New York, actually, I think, in community health organizations that have shown that an increase in fidelity, moving from that 1 toward that 5 in the scoring of adherence to the elements of the framework, has resulted in decreasing suicide attempts and completed suicides. So there is some research about that. And the largest effect out of all of those items and elements that I went through, and that's not all of them, that's just a portion of them, the largest effect of movement or improvement in adherence to standards is when there's movement toward lethal means systems, counseling and improving counseling on access to lethal means and lethal means reductions, and systematic quality improvement activities. Those two things are basically what you get the biggest bang for your buck out of when you implement this framework. Even though the entire framework is important, there are specific interventions that are more associated with improvement and reduction of attempts. So, as I said earlier, this is where we are as an organization, working on these things, continually working to get feedback from our staff, to use it to inform not only our training, but our quality improvement systems, getting clinicians to understand quality improvement and buy into it, trying to work within our organization and outside our organization to improve transitions, and building our ability to plan for lethal means safety. And again, a word about the staff surveys. There's multiple methods. I found in-person meetings, as as resource intensive as they are, as the best way to lay the groundwork for people responding, getting a higher response rate to surveys and getting more meaningful responses to surveys. So again, more words about lethal means. Encourage people to look into the online training and in-person training from CALM, or Counseling on Access to Lethal Means. There's also a wealth of materials that can be given to patients and clients and clinicians, overviews of things like firearm safety, medication safety, very practical tips that people can take with them and implement in their own setting, their own home. And then more education about the impact of access to lethal means, more education about the fact that reducing access, although not in and of itself treatment, is something that promotes a better outcome, that ensures safety and gives people some space and time to build strategies for people to cope with suicidal thoughts and to help people improve their functioning, become more resilient. Simply taking care of that fundamental exposure to risk and reduction to access to lethal means is a critical and fundamental step. And again, there's a lot of misconceptions about that based on multiple studies. Most recently, I noticed that about only half of people believe that limiting access to lethal means, including guns, which are of course the most lethal, can prevent suicide. And there's a lot of opportunity to increase understanding and knowledge, and I think that some of the basic materials, the basic educational resources are available, and our approach is that we all have a role, no matter what we do in the organization, in understanding suicide risk and knowing about those basic resources and sharing them with our clients and with the community. All of this information can be found at the Zero Suicide Framework. You can go on these websites, download the self-study, a toolkit, staff survey, and you can also access trainings from the Counseling on Access to Lethal Means training, all the way up to a list of resources on evidence-based practices and well-recognized clinical trainings like dialectical behavioral therapy. Access to those resources, from the fundamental and free to the slightly higher cost and more sophisticated, all available if you go through that Zero Suicide portal. So I'm going to stop sharing because it's not always easy to talk nonstop for 48 minutes. So now I'm going to stop.
Thank you, Mike. Looks like Dr. Mills has a question. How many people are on the team, and what's the size of the program or organization for which they're responsible? I think this is a question she and I had on Tuesday. I think I shared with you, we are planning to start the implementation, and that's one of the things, because we are kind of like within Wood System of Care, we are widespread group home. I think I shared with you, group homes, residential, and then outpatient. In Bucks County, and we have plans to expand in Chester County. So we are and our other affiliates are in New Jersey. So how do you really form that team?
Yeah.
Yeah.
We're not quite as diverse, but we do have some. We actually have some adult residential programs. So we have 4 CRR programs for adults with serious mental illness, in addition to a lot of community-based services. So we have about 400 employees. We're in Delaware, Chester, Montgomery, and Philadelphia counties. We have a number of outpatient sites, school-based sites. We deal with children from preschool up to early adulthood. How many people right now on our team officially? 7, I would say. We have a senior director, an experienced clinical director. We have who's been with the organization forever and has overseen many of the programs that we operate. We have a representative from our adult services division that I mentioned. We have our chief psychologist on the team. We have a case manager on the team, a blended case manager, who's in graduate school and is interested in this. We have 2 quality improvement people. We have an outpatient therapist, an experienced therapist who's been seeing children and adolescents for about a decade. So off the top of my head, that's the composition of our team. Tried to make it as diverse as possible. I think one of your challenges is going to be managing, the difference between providing, integrating your ID services and your behavioral health services.
Yeah.
So, I mean, you might have like one overarching team and then a couple subcommittees or something like that.
Yeah, I think that's the one of the things we were discussing about is how do we incorporate autism and ID individuals into that. And also, even in the outpatient, it's kind of like a mix. Yeah.
Yeah.
Are there any, I know our clinical directors and myself, we were thinking about the Columbia, even the assessment part of it. Is there like a specific thing for the individuals on the spectrum versus the normal? What do you guys use?
There's the standard, which I think applies to the normal or the standard one, which I think has been validated or standardized from age 12 up. Then there is, there's something, I forget exactly what they call it, but there's a Columbia screener it's for younger children and for individuals with cognitive challenges, something like that. So it's a simplified version of the screener that gives you options to elicit information in different ways, get the same questions answered in terms of, thoughts about not living anymore, intent, plan, but to elicit that information using different words. So I would check that out. It's called
Sure.
For Younger Children. And I do believe, it's adaptable to an extent for the ID population. But having worked at Melmark and other settings, I know that that's part of the challenge and that you have to find ways to adapt. Um,
Yeah, yeah. We need to come up with other means.
but I would
Um,
start by looking at the Columbia website and looking at that.
And how did you make, this is Dr. Mills, another question in the same part, is how did you reduce the sense of blame associated with the QI, quality initiative and root cause analysis, and also maintaining that accountability within the
Yeah.
staff or employees?
Yeah, well, it's an ongoing challenge, I mean, I think people respect me, um, and think that I have some kind of authority in the organization. Um, and what I tell them, um, is that I make mistakes all the time, and when we went through our joint commission survey, I was second guessing myself, saying I should have known this, I should have done that. I've been working in this field for years. Why didn't I think of that? And then I step back and I say, how can I use this experience to get better? And what do I need to do about, allocating my time? And that is what we all do as human beings. We continually learn based on experience. And that is what I want our quality improvement system to be. And that's the way I want people to think of it. How do you establish accountability while doing that, while reducing the fear or the sense of blame? Um, I think what you do is you say, you know, that we want to see evidence. We want to see evidence that things are implemented, that systems are implemented. And, so if a system exists and people are following the system, but within that system, something breaks down, that's understandable. If people depart from the system, that's where the accountability comes in. So if we've established a system, so, at the most fundamental level, let's say we never told people they should ask questions about lethal means. Um, and, all of a sudden something happened and we started, criticizing the individual person for not doing it
Not
without
doing.
any context. So I do think it's an ongoing battle. And I think one of the most important ways to balance accountability and diminishing fear is simply modeling that, in the way you interact and having leadership support that. We have a system, we expect that we're implementing this system, we understand mistakes are going to happen. But I think a lot of it comes down to leadership modeling and the way they interact with each other and with different managers and clinicians. I mean, we all know what it feels like to be blamed when you're dealing with your boss versus to be given constructive criticism. And I think that overall that's an important factor in this.
Mike, before I get to, there is one more question in chat. I have a question. So did you guys had, when you first started implementing, did they go through a specific training with the Zero Suicide Institute, or is it free, or do you have to pay for the organizational
We did not
standpoint?
we did not have to pay. Um, we did not have to pay. I think they do offer some consulting services. We haven't used them yet. And I don't know what they might not be free. I'm not sure. We didn't have to pay. I did feel like we needed to do a lot of research and invest a lot of time in the self-study. And I had senior management and senior clinicians involved in the self-study. I thought it was important that we have a logical and well evaluated approach to what we wanted to do before we just started rolling things out. So we didn't go through a formal training, but we sort of trained ourselves by making the implementation team do the self-study, talk about it, think critically about our processes, and then disseminate that to the rest of the organization. And you know, I mean, it was mostly or completely self-learning. The resources are there. We taught ourselves based on the resources.
That's helpful. Thank you. I think there is one more question in the chat. Is Tom Ginopoli, is there education provided on social media and, sorry, something is blocking, and cell phone use, and how that has a massive impact on the youth and adolescent population? Not sure what the current research is. However, I know there is a correlation between social media use and mental health.
Yeah. Are we educating our clients on cell phone use? I don't have a great answer for that. I know it's an important issue, and I know it's a challenge, you know, access to social media, you know, bullying, social media transmitting ideas about self-harm. I mean, I know that's a big risk area. I guess we try to incorporate that into our crisis prevention plans and safety plans, give people, you know, feedback on that, but I don't have the ultimate, you know, authoritative source on the best way to address that. But since you brought up cell phones, I can tell you that one of the things that I found helpful is that there is a Columbia screener app that you can
Yes.
download, and you can, you know, which an individual can use to assess themselves, and a clinician can use to sort of check in the moment if you're evaluating the risk level correctly. So when I do trainings, I pull out the app, right? And I pull out the app and I download it. Same thing with the Stanley Brown Safety Plan. There's also an app for that you can download. I wish I had a better answer about social media, but I know that hopefully.
Thank you, Kristen, for the link.
Yeah, thank you.
Anyone has one last question that they want to ask? Okay. Thank you, Mike.
Thank you, Doctor. Good seeing
Thank
you.
you. Yeah, good seeing you too. We'll be in chatting more about
Okay.
this. Yeah.
I'll talk to you soon. Take care.
Yes, yes. Thank
Thank
you.
you. Bye,
Bye.
everyone.